Good afternoon or good morning, everyone. My name is Mina Hanna. I'm Associate Professor of Radiology at the University, West Virginia University, and I'm the Section Chief for the Cardiovascular and Thoracic Imaging. Welcome, everyone, to the March 2026 Curious Cases webinar. These webinars are meant to be informal and interactive, so please feel free to respond to my questions and ask your own if you have any during my presentation. So today we'll try to go over 10 different cases, curious cases, some of them are cases that we usually see in our daily work, but maybe of different presentations. So let me start with this first case. If you would like, can you please tell me what is the abnormalities in this image? Anyone can answer or I can go through it. Okay, so this is a nice case, a rare case actually of aneurysmal dilatation of the right atrial appendage. As you see here, the right atrial appendage is almost as large as the right atrium itself. Right atrial or atrial appendages generally is an important structures in the heart when you evaluate the heart, not only because of their shape, but also because they can have thrombi hidden in them. They can have like abnormal shape, and they are important in the evaluation for closure devices, especially on the left side. The shape of the atrial appendage, generally left and right, can help us in evaluation of congenital heart disease. Right atrial appendage is a small conical muscular pouch attached to the right atrium of the heart. Its margins present a dentated edge. It projects from the upper and the front part of the sinus forward and towards the left side, overlapping the root of the aorta, as you can see here. The right auricle, along with the right atrial body, is lined with pectinate muscles that form the network of hills and furrows that give it a trabeculated surface, as you can see here. On the left side, left atrial appendage is a small muscular extension of the left atrium arising near the left pulmonary veins. It arises anterolaterally and lies in the left atrioventricular sulcus atop the proximal portion of the left circumflex artery, as you can see here, and this is the left circumflex artery. It has been described as a long, narrow, tubular, wavy, hooked appendage with narrow junction and granulated lumen, and its shape, its direction, its size, as I mentioned, is important for insertion of left atrial appendage closure device to avoid formation of thrombi and embolization in the future in patients with atrial fibrillation or dilated left atrium and so on. Giant right atrial appendage, atrial aneurysms involving the free wall or atrial appendage are rare entities in cardiology practice and may be associated with atrial aneurysms or embolic phenomena. As you can imagine, it may have a slow flow and thrombi formation. This is our next case. Anyone wants to give it a shot and tell us what is going on here?
Apical hypertrophy.
Exactly. This is apical hypertrophic cardiomyopathy. Excellent. Thank you. So atrial hypertrophic cardiomyopathy, as you can see here, not all the left ventricle is thickened, but only the apical portion of the left ventricle is thickened. These are two different cases. You see one here and you see one there. And very nice thing when you try to see the shape of the left ventricle, it looked like a spade appearance or like a conical appearance, and it is very pathognomonic for this entity. Hypertrophic cardiomyopathy is diffuse or segmental left ventricular hypertrophy with a non-dilated and hyperdynamic chamber in the absence of another cardiac or systemic disease capable of producing the magnitude of hypertrophy that is evident. As you know, if the patient has aortic stenosis or hypertension for long time, systemic hypertension can develop left ventricular thickening. If the patient with infiltrative disease like amyloidosis, they may have left ventricular thickening. So we call it hypertrophic cardiomyopathy if there is no other entity causing thickening of the left ventricle. The usual diagnostic criterion for HOCM is a maximal left ventricular wall thickness greater than or equal to 15 millimeter in the end diastolic phase. Normally, in the adult population, the left ventricular thickening is up to 12 millimeter. 12 to 15 millimeter is borderline, and we can see this little bit increased thickness in the athletes, but above 15 millimeter is considered at end diastole something abnormal. There are different kinds or different types of HOCM, as we can see here. This is the normal left ventricle. This is asymmetric or septal HOCM that can cause left ventricular outflow obstruction, and this is the commonest form we see. Asymmetric with septal HOCM without LVOT obstruction, so there is diffuse interventricular septal thickening. Symmetric HOCM concentric, like what happens with aortic stenosis or systemic hypertension. Apical HOCM as the one we saw, mid-ventricular HOCM only, mass-like and non-contagious HOCM that can have different lesions in the left ventricle, and they are not tumors, they are not neoplastic, they are just hypertrophic cardiomyopathy. This is another case. As we can see here, there is thickening here, mainly towards the apex of the left ventricle, something like we saw in our cases to start with. This is a case, another case of hypertrophic cardiomyopathy where you see diffuse thickening, not only along the septum, but you can see it here along the anterior wall, inferior wall, and as you go more to the mid wall, you can still see some thickening here. And most important thing is to measure the thickening during the diastole, because during systole, the whole left ventricle is thickened anyway. This is when you go more laterally or more towards the septum, you find it thickened, but in the mid wall, it looks like if it's less thickened, but with measurements, it is equal or more than 15 millimeter in thickness. Another patient here with septal thickening, and the measurement here is about 23 or 24 millimeter thickness. Can anyone explain to us what we are looking at here in this patient? We are still talking about the hypertrophic cardiomyopathy. What do we see here in these images?
So essentially in these patients, we want to see how much of the myocardial mass is enhancing. If there is certain threshold, usually I believe that is 15%, sorry, I'm blanking on the number right now, but this will make the patient at risk for sudden cardiac death. So we can calculate the degree of enhancement, and we can see how much is that enhancement based on the in relation to the myocardial mass.
Yeah, perfect. Thank you. So as you just mentioned, there are extensive patchy, mainly mid-wall myocardial enhancement. And as you can see, it is going here from the apical segments, mid segments. You start to see papillary muscles here, less less evident in the basal segment, but you still see some here. So there is extensive patchy mid myocardial enhancement. This is not the commonest enhancement we see with hypertrophic cardiomyopathy. The commonest one is you see enhancement at the attachment of the right ventricle into the interventricular septum. So this is the commonest one, but as you exactly mentioned, the degree of enhancement correlate with the prognosis of sudden cardiac death or arrhythmias. So let's review quickly what are the rules of cardiac MRI in hypertrophic cardiomyopathy. What we have to mention and what gives the MRI the upper hand above like echo, above CT, and we have to mention in our report. So it is important in definitive diagnosis and phenotyping. As we mentioned, there are different types of HOCM, and MRI can help us differentiate between them. It offers superior spatial resolution, providing precise measurements of the maximal wall thickening and identifying hypertrophy in areas often missed by echo, such as the apical or anterolateral walls. And as you just mentioned in the description, if the or you mentioned the enhancement, sorry. So in the thickening, we mentioned that 15 millimeter and above is considered significant thickness, thickening of the myocardium. Above 3 centimeter or 30 millimeter is considered also high risk for developing arrhythmias. Not as sensitive as the enhancement, but the thickening of the myocardium also can put a risk for developing sudden cardiac death. Tissue characterization with the mapping and with the LGE and mapping, late gadolinium enhancement is essential for identifying myocardial fibrosis, which is linked to the prognosis as we mentioned. T1 mapping and extracellular volume quantification allow for detecting diffuse fibrotic changes. Another important thing, which is risk stratification. So once we have the thickness, once we have the enhancement, the degree of enhancement, this can stratify our patient, how risky or the prognostic value for those patients in the future. So extent of LGE is a key marker for prediction sudden cardiac death and help to determine the need for implantable cardioverter defibrillator or ICD. And as we mentioned, the threshold is 15%. These are high-risk people. However, some institutes put 10 to 15 to be high risk to help those patients early without reaching to a critical point. But if you find enhancement less than 5%, these are usually low-risk patients, and we just keep following them up to see the progression of the disease. It helps also in differential diagnosis. Cardiac MR accurately differentiate who come from other conditions such as cardiac amyloidosis or Fabry disease, which can mimic its appearance. So MRI help in diagnosis, follow up, risk stratification, and differentiating it from different other diseases. You can see here in this literature illustration, important when you say there is enhancement of the myocardium is to relate this enhancement to which part of the myocardial thickening, like subendocardial or mid-myocardial or subepicardial enhancement, and also to localize it to which segment of the myocardium, because different diseases involving the myocardium has different predilection for the enhancement. Some diseases like the septal wall, others like the lateral wall. If it is following vascular territory, it could be ischemic induced cardiomyopathy, and these all are important to relay the disease to which part of the myocardium. This can show us that the enhancement, different kinds of enhancement, can let us put this enhancement in a short differential diagnosis list and start to go behind this. And if the MRI is not 100% diagnostic, we can go for endocardial biopsy guided by the MRI abnormalities. Okay. Next case, what is your diagnosis? Anyone can take this?
Number 4.
Number 4, excellence. Thank you. So there is lipomatous hypertrophy. Sorry. So there is lipomatous hypertrophy of the interatrial septum. As you can see, the interatrial septum is much thickened, and it has fatty signal intensity. And the thickening we are looking for is 2 centimeter and above, or 20 millimeter and above. It is a benign condition characterized by brown fat accumulation in the interatrial septum linked to increasing patient's age and obesity. At histologic analysis, lipomatous hypertrophy manifests as an unencapsulated mass that can contain adipocytes, myocytes, mild interstitial fibrosis, and the lesion is often asymptomatic but is associated with atrial arrhythmias, altered B wave configurations, the recurrent pericardial effusions. CT and MRI shows this smooth, non-enhancing, marginated fat-containing lesion in the interatrial septum. It has a characteristic dumbbell shape or dumbbell shape appearance because the septum, which is closing the fossa ovalis, doesn't have fat going into it. The fat is only at the periphery where the two layers of the interatrial septum comes together. But the middle part has a single layer, so there is no much cells goes between these two layers, like the periphery. So this dumbbell shape appearance is characteristic for this. Another thing for this lipomatous hypertrophy of the interatrial septum is that it is FDG avid because it's a brown fat. So we have to be very careful when we see an FDG avid lesion in the heart to go back to the CT and the MRI and make sure that there is no metastatic disease. And this lesion is following fat in all sequences, like this MRI here shows fatty signal intensity, like the pericardial fat, like subcutaneous fat. So it is lipomatous hypertrophy of the interatrial septum, as we can see here. Okay. Going to the fourth case, anyone can give a shot to this one?
Maybe 3?
Excellent, yes. So this patient has, can you tell me what is going on in the left ventricle before we go to the next slide?
I think it appears kind of hypokinetic.
Excellent,
Sorry,
yes.
I'm on my phone. I'm walking, but yes, hypokinesis is dilated as well.
Exactly. And also, additionally, there are prominent trabeculation here.
Yeah, I was about to say that, but I wasn't sure.
No, good for the phone picture, like it's too small. Thank you. So this is a case of left ventricular non-compaction, and you can see it in this patient with congenital diseases and chromosomal diseases like Duchenne muscular dystrophy. The best diagnostic clue is to find the ratio of non-compacted end diastolic myocardium, this trabeculation, to the compacted diastolic myocardium more than 2.3 to 1 in more than 3 segments, because you can normally see it in 1 or 2 segments. But if you find this ratio 2.3 to 1 in more than 3 segments during diastole, this is a diagnostic criteria for the non-compaction. Sensitivity 86% and the specificity 99%. You can see here this an MRI picture for this patient taking the whole left ventricle, and exactly as you mentioned, with non-compaction, you may find, especially with middle age, as the patient grow, the patient getting older, the myocardial function start to get weak, and the contractility start to decrease over time. And you can see trabeculation here. It may not too prominent here on the screen, but in the real images, when we measured it, it was more than 2.3 to 1. Okay, next case. Who can take this case?
LAD?
LAD, exactly, thank you. So you will see here subendocardial infarction or enhancement, late gadolinium enhancement along the anterior wall, starting from the mid left ventricle to the apical left ventricle, and even wrapping around a little bit the apex, and this goes along the course of the LAD. Perfect. And if I ask you, this myocardium is viable, so you recommend doing revascularization, or you will tell the cardiologist this myocardium is non-viable, we can't do revascularization, will not benefit the patient?
I think it's viable.
Yeah, because it is 50% or less than 50% myocardial thickening. Thank you. 59-year-old male, this is a companion case, patient with history of coronary artery disease, presented to the ER with a new chest pain. And as you can see here, there is thinning along the lateral wall, but the rest of the myocardium has normal thickness. So this thinning with the history of coronary artery disease, so probably this is a result of old myocardial infarction. So the patient proceeded in the exam and they did contrast imaging, and we found that along the lateral wall there is transmural enhancement, and this means it is non-viable. But there is something here, like in subendocardial area, with normal wall thickening along the anterior wall. So this patient, in addition to the old or chronic myocardial infarction laterally along the LCX, there is a new anterior wall along the LAD subendocardial infarction, which has like about 50% thickness, myocardial wall thickness. And this could be viable if they would like to do revascularization for this patient. And we see this patient, probably it could be the same patient we presented the image at the beginning. So this patient we see here, subendocardial enhancement along the anterior wall and lateral, almost transmural along the LCX territory lateral wall. Okay. Do you guys have any questions so far as we go in the best cases?
No, really good cases. Thank you.
Yeah, great cases.
Okay, so who can take this one?
So on the left, it's the T2 stir. I feel like the myocardium of the left ventricle, it is hyperintense compared to the skeletal muscle. And then on the PSIR short axis, it looks like at that septum, you have quite a bit of mid-myocardial or intramyocardial LGE, maybe more so near the base. So without any additional information, I'm guessing this is a myocarditis workup, and I think we have criteria here to meet or support myocarditis.
Okay, any other thing you can find it in these two images?
Let's see. Some pulmonary opacity, maybe a pleural effusion,
Okay,
maybe
let's
pericardial
go.
effusion.
Yes, so we are looking here. If you see here, you will find that the pericardium here all around the heart has high signal intensity, which is not usually prominent like this because this is stair images, so the fat is suppressed. So all this signal is edema signal or fluid signal intensity in the pericardium. And when we go to the phase sensitive inversion recovery post contrast images, we will find that the fluid here is suppressed. So if there is any high signal intensity around the heart, this is in the pericardium. You see high signal intensity here around the heart. So there is pericardial enhancement. In addition to maybe some myocarditis here. The signal of the myocardium is not too high here because usually I like to compare it with the spleen. So if it is as high as the spleen, it is high signal intensity. If it is less than the spleen, and you are right, it could be very close to the muscles of the chest wall, this is the normal. But the muscle of the chest wall is not well seen here, some like not as evident as the myocardium. So there is no much signal here. So there may be myocarditis before, yes, but what is evident now and the patient presented with chest pain is a pericardial enhancement or pericarditis with some pericardial effusion as well. Okay. If I show you this next part, or this what's called real-time cine images, what abnormality can you say in this one?
Looks like the little septal bounce.
Yes, perfect, perfect. And what happens during inspiration? So wait
So,
for it. Yes,
oh my gosh. Was it the interventricular dependence? I think it's a technical
exactly,
term, but it becomes flat.
exactly. So yeah, definitely there is septal bounce during the cardiac contractions, and during inspiration, deep inspiration, there is some flattening of the interventricular septum, which is interventricular interdependence or ventricular interdependence. And so this finding, you will see it in which abnormality?
Constrictive pericarditis?
Constrictive pericarditis. However,
Or
recently
constrictive physiology? Or
exactly. So exactly. So we have been seeing this in patient with constrictive pericarditis for a long time. We see thickened pericardium, but in this patient, the patient still have inflammation on the pericardium, still active pericarditis, and the pericardium has minimal thickening. And in the CT, there is no thickening, much thickening and calcification. So this is a new entity we start to see, like patient with pericarditis and the constrictive physiology, but not definite constrictive pericarditis. So the key CMR feature for acute pericarditis is pericardial thickening, often more than 4 millimeter, best visualized in steady state free precession or SSFP semi-sequence, pericardial effusion, variable amount of fluid, usually between pericardial layers, LGE, high intensity bright signal indicating active inflammation. Myocardial involvement can be there, like perimyocarditis, if there is concurrent myocardial involvement. Uh, if there is a constrictive pericarditis, like all the cases with thickened pericardium calcification, you may find thickened pericardium fibrocalcific changes, often appearing as a dark low signal intensity strip in CMR, septal bounce, as we saw in this case here, rapid abnormal motion of the interventricular septum during early diastole, and respirophasic septal shift, or what we call it ventricular interdependence or interventricular interdependence. Ventricular deformity, conical or tubular shaped ventricle, sometimes with free wall tethering because of the pressure of the constrictive pericardium on the heart. And hemodynamic signs, dilated inferior vena cava IVC, and on-phase contrast imaging, more than 25% reduction in mitral inflow velocity during inspiration. And all this because the heart is not giving space for the blood to fill in during diastole, and there is no much space for the heart to dilate and accommodate the blood coming back to it. Next case. Anyone can take it? Even if you don't know the diagnosis, just tell me what do you see, what is the abnormalities you see
It
in this.
appears on the left to be like, is it a thrombus? Oh, sorry, I cannot see. So what is the sequence? Is a MAG. Okay. Yeah, thrombus in the left ventricle, layering
Yes,
thrombus maybe? And
yes.
again, dilated left ventricle.
So we see here left
Mhm.
ventricular intraluminal signal void lesion, and in this delayed contrast enhancement or LGE sequence, and it's inside the lumen, and it is probably thrombus formation. What other abnormalities do you see in these images? So this is LGE image. What else?
LG images
Yes,
also has left pleural effusion, but of course you're asking me about the heart. Is it
that
like some enhancement in the pericardium again? I'm not
some
sure.
pericardial enhancement.
Yeah,
These
there.
are not these are not SPIR. So maybe maybe some fluid,
Okay.
maybe some fat, although I see some fat suppression here. So probably either we're talking about fluid or enhancement. Could be enhancement, yes. What else? What about the endocardium?
The endocardium. Oh, it's okay. Is there a little bit of enhancement there too? Like
Yes.
subendocardial?
So this
Oh,
subendocardial,
gosh.
yeah, so there is subendocardial enhancement. So the next question, is this vascular territory enhancement kind of, or it's diffuse enhancement?
It's more of a diffuse enhancement in a non-ischemic pattern.
Exactly. So all this subendocardium outside this thrombus is enhancing, and you see it also in the short axis here. So there is diffuse subendocardial enhancement, and there is multiple small thrombi within the left ventricle. Okay. So when do you see this subendocardial enhancement, diffuse non-vascular distribution? So you can see this in patient with a amyloidosis, but you will see more myocardial thickening. You can see it in patient with systemic sclerosis sometimes. And in those cases, like this case, patient with eosinophilic endocarditis or Loeffler's endocarditis. And this kind of cases, there is increased eosinophilic level in the blood, and this causes inflammation of the endocardium, which heals with fibrosis. And you can imagine that you have fibrosis inside the heart that can initiate the process for thrombi formation. So you always see this endomyocardial fibrosis or subendocardial enhancement with multiple thrombi inside the left ventricular lumen. Good. So Loeffler endocarditis is an uncommon restrictive cardiomyopathy associated with hypereosinophilic syndromes. Loeffler's endocarditis is an interchangeably referred to as eosinophilic endomyocardial disease or fibroblastic endocarditis. The condition characterized by eosinophil-mediated cardiac damage, inflammation, leads to fibrosis, and this causes restrictive cardiac disease, resulting in impaired heart relaxation and diastolic dysfunction. Okay, good. Next case. Anyone can take it? The abnormality here is subtle.
Mitral
but
regurg.
yeah, great, great. So you see here there is a regurgitant jet. So there is stenosis and sorry, this is wrong. This should be the one above it. Mitral regurgitation, this one. Sorry guys. So this causes the regurgitation. Do you see this jet here? So there is a regurgitant jet here going from the mitral valve backward. It is very subtle. This one can show the jet. So do you
Oh,
see
wow.
this patient has mitral regurgitation, has aortic stenosis and aortic regurgitation. You see barely aortic valve movements. The aortic valve is thickened and barely movements. So it is like more or less little bit open and not closing or opening. It is just like this. So it goes regurgitation and stenosis in the same valve. And you see this patient also has marked thinning out of the left ventricular wall. So probably all this is result of prior ischemic heart disease as well. Okay, talking about valves, anyone can tell me what you see in this patient? Bicuspid
Valve.
aortic valve, perfect. So bicuspid aortic valve, it is like one of the common questions we usually hear about it in the board. So what are the other anomalies that can be associated with bicuspid aortic valve, and which kind of syndromes that have this anomaly most common?
So ascending aorta aneurysm.
Usually bicuspid due to eccentric jet cause ascending aortic aneurysmal dilatation over time, right? But we are talking about another anomalies. congenital anomaly.
coarctation,
Coarctation of the
Turner
aorta,
syndrome.
exactly, Turner syndrome. So when you see, usually we taught it like this way. When you see one cardiovascular anomaly, start to search about another anomalies that could be associated with it. So just don't stop on one of them, just go look for other anomalies as well. Perfect. Another case talking about valvular diseases. Anyone can give it a shot?
I think it's mitral prolapse.
Yeah, it's very nice mitral prolapse here. Okay, and for mitral prolapse, try to stop it here. So we usually put an imaginary line at the attachment point of the mitral annulus and measure the height or the depth of the mitral leaflet going beyond this line. So usually up to 2 millimeters is acceptable. More than 2 millimeters is considered prolapse. And we can, sometimes it happens in the two mitral leaflets or mitral cusps, and sometimes one only, like anterior or the posterior one. So we can go through different images to see which one of them is affected. Okay, next case. Anyone can see anything abnormal here in this image?
Yes, anomalous origin and course of the RCA with slit ostium.
Exactly, perfect. And we used to call this, or we will still call this one, which kind of RCA anomaly? So there
The
are different,
malignant
yeah,
interarterial course.
interarterial course, exactly, and sometimes we call it malignant course of the RCA because it could be compressed during arterial, during a systole between the two arteries or during the movement of the aorta and can cause decreased blood flow to its supplemental area in the right side of the heart or inferior part of the left ventricle. This is not one, I keep putting wrong things. This is anomalous origin of the RCA. Where is this? It is not here even, so I messed it up. Sorry, guys. So it should be anomalous origin of the RCA. And this can show you more about this. See how it has some intramural part. Some of the course is intramural course and slit-like, and then it goes to its normal. So sometimes to treat this, if it's symptomatic, they can do deroofing or unroofing. They remove this part of the aorta and make this opening wide, or they can take it out from here and implant it here. Definitely, if this anomaly is for the left side, left main, having this intramural course, the risk is higher because you know the left coronary artery is supplying most of the left ventricle. So if something happened in the left coronary artery, it can cause more damage and sudden cardiac death or something like this. So it is more serious if it's on the left side. These are 3D rendering images, and you can see how the right side is going slit-like here, and then going back to its normal course. Okay. This is my last case. So let me show you what we. Anyone see something interesting here? Maybe difficult case.
Does the patient have any particular symptoms? Because what I'm seeing is, focused on the aortic valve prosthesis.
Right.
Maybe the leaflets are a little thick, and I think under that, is it the right? There may be an aneurysm. So I'm wondering if this is endocarditis or
Yeah,
trying
as
to
you
figure out
see,
maybe.
so definitely I agree with you that this is post-surgical case. So it is very important as a learned lesson for any post-surgical case to have a pre-contrast as well, because many of the post-surgical material are high density and can be mistaken for peri-surgical leak or blood component or contrast leak. But this patient has perivalvular contrast coming here outside around the surgical change. You have some here also as well. We have some here. So
Yeah.
around the valve itself. Yes. So this patient has ascending aortic aneurysm repair with aortic valve replacement. And then this patient presented with chest pain following surgery. I don't remember exactly how far or how long he had this pain. And when we did a CT, as you mentioned, there is thickening in the valve leaflet, the bioprosthetic valve leaflet, and we saw compared pre-contrast and post-contrast, we saw some contrast around the aortic valve. So this we call it paravalvular leak, or even sometimes they call it, if the sutures are dehiscent, they call it suture dehiscence following surgery with pseudoaneurysm or leak around the implanted or transplanted valve. So paravalvular leak and dehiscence are serious complications following aortic valve replacement or surgical or TAVR, where an abnormal blood flow occurs between the prosthesis and the cardiac tissue due to incomplete sealing or partial detachment. It can cause heart failure, severe anemia, increased mortality for those patients. The key aspects, the causes for this major cause include native annular tissue friability, significant calcifications in the original valve, prosthetic valve endocarditis, as you mentioned. It could be due to infection that makes the tissue friable, and this leak start to happen around the transplanted valve, which is getting infected as well, so causing perivalvular abscess formation, not only blood leak or technical issue during the implantation. The incidence is 5% to 17% of the surgical cases and is a known risk of TAVR, often within the first year, because TAVR usually is implanted in a very calcified valve. So when TAVR goes in place, it can crush the valve and can cause tears around these calcifications and can cause complication. One of them is this one. Symptoms range from asymptomatic to acute heart failure, hemolysis, destruction of red blood cells, and severe murmurs as well. Diagnosis, primary diagnosed during or using echocardiography and CT to evaluate the severity and location of the leak. The management differs from patient to patient, so there may be conservative management. If it's mild, asymptomatic leaks are often monitored to see if they are increasing or not, progressing or not. Interventional percutaneous closure, putting plugs or coils is valid. Less invasive alternative to surgery for symptomatic patients. Surgery reoperation is required for severe dehiscence or when interventional methods fail, though it is high risk because or you can imagine that the tissue is friable, very thick, so putting suture, it will not hold in place. There is high risk of bleeding, so the field itself is not a good field for reoperation. So these are my cases. Thanks a lot for your attention and attendance. And please let me know if you have any questions.
Thank you, Mina.
Thank you so much.
You are so welcome. And thanks for your time, everyone.
Thank you.
Have a good one.